not with you, but I'm very pleased to be participating in SABPA. I've learned a lot already today from listening to the other speakers. So it's been a really tremendous opportunity to learn, and I'm grateful for the opportunity to be part of the program. So you see that this is going to be a little bit different from the other talks. I'm not going to focus on one drug or one platform. I'm going to try to give the 10,000-foot view of what I see happening in Alzheimer's disease and where I think the opportunities for biotech and pharmaceutical companies are. Here are my disclosures. I've consulted for a lot of biotech companies and pharmaceutical companies to help them find drugs for Alzheimer's disease. I'm also pleased to be supported by a fair number of NIH and NINDS grants. The things I'll be talking about today, I'll start with neurodegenerative disease. I'll be brief about that. We've heard a lot about it already. Concentrating on the biology, and I want to call attention to the biomarkers because the biomarkers have become absolutely essential and absolutely so exciting at this moment. I'll mention digital technologies because I think that's another opportunity for biotech that needs to be exploited. Talk about the drug development and trials that are in progress now and how the financing is being done and what that landscape looks like now. So to start with neurodegenerative disorders, then we've heard a lot about this already, that a great shared feature is the misfolded and then aggregated protein. So in Alzheimer's, of course, amyloid and tau, Parkinson's dementia with Lewy bodies and multi-system atrophy, are the alpha-synuclein protein, ALS, and half of the FTD patients share TDP-43. And then the other half of the TDP patients, the FTD patients and cortical basal degeneration, PSP, and CTE all share tau. Huntington's disease is unique in having Huntingtin. But the point is there's a common pathology that extends across neurodegenerative disorders, which represents an extraordinary opportunity if we could crack the code that is represented in misfolded proteins. So I've just shown you some examples there of the amyloid protein in AD, TDP-43 in ALS, alpha-synuclein in Parkinson's, and the tau protein in PSP. Of course, beyond misfolded proteins, there's inflammation, and that was emphasized in the first talk this afternoon, as well as neurodegeneration. Synaptic loss and circuit dysfunction are key. They are the foundations of human thought. And their erosion in the neurodegenerative disorders accounts for the dementia and behavioral changes. Transmitter loss contributes to that. So shared biology then can lead to shared therapies. And there is one such example. Rivastigmine is approved for Alzheimer's disease and Parkinson's disease because both have marked loss of cholinergic system neurons in the brain. That's a symptomatic treatment. Of course, we would love to extend this to disease-modifying therapies, but at least it's a model for a transcendent molecule that would act across disease. Promising then are tau targeting molecules across many diseases, inflammation targeting molecules, such as we heard of today, and alpha-synuclein targeting, which we've also heard quite a lot about today. So thinking about these disorders and their shared biology, what are the biomarkers that are emerging that can help guide us in drug development and maybe even in the clinic eventually? So the biomarkers in Alzheimer's disease have made remarkable progress. There's been less progress, unfortunately, in other neurodegenerative disorders, but we're hoping that Alzheimer's disease will pave the way for biomarkers in other neurodegenerations. We're using the ATN framework in Alzheimer's disease, that is amyloid, tau, and neurodegeneration. And the ATN framework has become very important in terms of Alzheimer's disease diagnosis and drug development, and I'm going to show you how this is working. For biomarkers, we've had brain imaging for some time, of course, starting originally with MRI and then going to FDG PET, and now more recent molecular imaging with amyloid and tau PET and many other ligands. We've had CSF studies for many years, and the real excitement now is in the plasma biomarkers. And I'll show you where we are with those plasma biomarkers. So just to give you a sense of the imaging biomarkers in the upper two images, I'm showing you first a negative and then a positive example of amyloid imaging. So you see that red signal is the amyloid deposited in the brain. It must extend to the cortical surface in at least 3 areas to be a positive scan. In the lower two images, I'm showing you the tau PET. This is fluortaucipir. This is the only FDA-approved tau ligand. It's very good for Alzheimer's disease and not very good for the other tauopathies. So there's a big push to try to find a tau ligand that would tell us more about the non-AD tauopathies. So at MRI, we have atrophy. In FDG, we have hypometabolism. Amyloid and tau show us the fibrillar form of the protein. So amyloid PET is fibrillar amyloid plaques, and tau PET is fibrillar neurofibrillary tangles. Whereas in the CSF, for example, you see the monomeric form of these molecules. So they are not measuring the same things, and they do not behave the same way. SV2A PET is, I think, very exciting because it shows us synapses, and is really emerging, I think, as an important tool. And then we see preliminary examples of PET imaging for inflammation, mitochondrial function, and many other processes. So here are the imaging, CSF, and plasma biomarkers for the ATN system. So I'm showing you there amyloid, tau, and neurodegeneration. The brain imaging then would be amyloid PET for amyloid, tau PET for tau, at least neurofibrillary tangle tau, and MRI and FDG for neurodegeneration. In the CSF, our best measure is A-beta 42/40 as a ratio. For tau, it's p-tau 181 and 217. I see that I've made a mistake there, 217. And for neurodegeneration, we have total tau, which is not a particularly good marker, and neurofilament light, which is a marker of axonal degeneration, and neurogranin, which is a marker of synaptic degeneration. In plasma, then, we have A-beta 42/40. How exciting is that? We can see it in the plasma. Even better are p-tau 181 and 217. Again, I apologize for the error. And we can measure total tau and neurofilament light in the plasma. We do not have a measure of neurogranin in the plasma. These are all preliminary, right? They're first steps. We've had them for a couple of years now. We're going to go far further than this. And the ATN framework is elastic. So it will allow other markers to be incorporated. And those markers are biotech opportunities because we need them, and they're going to have commercial value. So plasma biomarkers are where the action is at this moment. They're less expensive than PET. They're less invasive than lumbar puncture. Of course, you can readily repeat them during a treatment episode or during a clinical trial. Of course, they're familiar to clinicians. So how great is that? That's why we think they will go readily into the clinic once we have proven their utility. They can be used for screening. And just like we use the PSA or cholesterol test now, we could eventually use those the same to detect early and non-symptomatic, asymptomatic Alzheimer's disease. They have many drug development applications and many clinical applications that are possible. Now, plasma biomarkers also do not provide one thing, which is they provide no geographic understanding. So when we look at brain imaging, we can see, well, here's where the amyloid is deposited and here's how it's removed. You saw how restricted the tau was in the image that I showed you. So you can see that the tau is geographically placed, and you can determine whether you're limiting the increase in the tau signal by the intervention. So there are important outcomes that are measurable by imaging that we cannot get to with plasma, but plasma can do an enormous amount. And our understanding is evolving. We're at a place where many of the studies have been retrospective in well-characterized populations, and they're performing well. But we have to know that they are going to perform well prospectively in less well-selected populations. And that's the process that we're involved in now. So I mentioned that ATNX or ATXN is an elastic framework. So this is work done by Harold Hampel on the ATXN framework and by Jeff Kinney and I on what are the representatives that are possible in ATXN. So of course we have ApoE4. I've mentioned that we have 42 to 40, 181, 217, and 131 in p-tau. We have vascular markers, growth hormones, a number of omics, oxidative stress measures, neurodegeneration measures, synaptic plasticity measures, inflammation. It's so important that we get to these brain markers, to these biomarkers on inflammation. You saw how important that was as we were talking today. And then, of course, there are a number of genetics and genetic hazard scores that are being generated at this time. What about clinical biomarkers in clinical trials? Well, there are three ways to get a biomarker into a clinical trial. One, you put it into the clinical trial itself. It's then limited to only that trial. It does not provide validating information for any other trial, but it can be helpful in terms of confirming either the disease-modifying effect or possibly the target engagement effect of your molecule. If there's a scientific consensus, it can be used across trials. This would be true, for example, of cholesterol. It never went through a qualification process, but it is widely accepted for what it indicates. And then there's a separate qualification process. If the molecule is taken if the biomarker is taken through the qualification process, it can then be accepted in all trials without additional qualification. So that's a great place to be, and I encourage people to think about how to qualify biomarkers. How do we think about putting the biomarkers then in the drug development context? One is defining the purpose or context of use. This is required by the FDA. And there are 7 types of biomarkers that are identified by the FDA. Each of the biomarkers then would have one of these contexts of use or more, but they must have at least one. So that could be a risk biomarker, a diagnostic biomarker, a monitoring biomarker, a prognostic or a predictive biomarker. Prognosis is what happens when you look at a biomarker and you say this patient is going to decline or this patient is not going to decline. Predictive is this patient is going to respond to the drug, or this patient is going to have side effects from the drug. And so it predicts a therapeutic response. Pharmacodynamic biomarkers can either be indicative, as I mentioned, of disease modification or target engagement. And of course, safety biomarkers. We've had them for years in the form of EKG and liver function tests. Now, in the development of the monoclonal antibodies, of course, we're using MRI as a safety biomarker for amyloid-related imaging abnormalities, or ARIA. So these are the contexts of use that must be defined for any biomarker under any of the 3 circumstances that I said. Of course, it's also important to identify the patient risk and the patient benefit from the use of this biomarker. If it was wrong, would it put the patient at a great disadvantage? That's a risk. If it is right, does it put the patient at a great advantage? So here's some examples of the context of use of biomarkers currently available in Alzheimer's disease research. So our biggest susceptibility or risk biomarker is ApoE genotype, with the ApoE4 being predictive of early onset and of faster progression in the early periods. Of course, Alzheimer's disease autosomal dominant mutations also are risk genes and are essentially fate genes. Diagnosis would include amyloid PET and CSF A-beta 42 to 40. We're not quite there with plasma 42 to 40, but we're very close, and I think we'll eventually get there, and soon. Monitoring could be amyloid PET, although of course that's very expensive and difficult to do repeatedly, the same with tau PET. But just think what we can do now with plasma p-tau 217 or plasma p-tau 181. You see them as the monoclonals are acting, the plaques are being removed from the brain, and these biomarkers are being reduced at a far greater percentage than the changes in the clinical measures. Pharmacodynamic biomarkers would be within the ATN framework and usually target engagement. Predictive, I mentioned, is ApoE4. It predicts ARIA, and amyloid beta plaque, amyloid plaque lowering is thought by the FDA to be reasonably likely to predict clinical benefit. So you see the word predict there used by the FDA. It predicts clinical benefit. Prognostic, p-tau 181 and 217, as well as tau PET, indicate that the patient will advance from that point. And safety biomarkers, as I mentioned, include MRI, liver function tests, and EKG. A specific biomarker can have several roles. You see two roles here for ApoE. Their role depends on the defined context of use, so very important to think about the context of use. I mentioned amyloid PET is the basis for accelerated approval. That also establishes a pathway for accelerated approval. So another biomarker that was thought to be reasonably likely to predict clinical benefit could be the basis for accelerated approval. And I think that's an important forward-looking attitude. So let's think about therapeutics and clinical trials. Alzheimer's disease, of course, we've got three monoclonals in action right now. We have aducanumab approved in 2021, lecanemab approved in 2022. We have donanemab, which will be reviewed in mid-year. So we have three monoclonals that are in action here. We have brexpiprazole, which I think will be approved this year for agitation. Of course, I don't know for sure, but it had a very good phase 3 trial of treatment of agitation, and suvorexant had a positive phase 3 trial for insomnia. ALS has had 2 approved drugs, and Parkinson's disease has, of course, symptomatic therapies, but no disease-modifying therapies that there's a consensus on at this time. Now, here's the work that I do to track the drugs in the pipeline. This is the 2022 pipeline. I'm currently working on the 2023 pipeline, though it looks reasonably similar. So the inner circle is all the phase 3 drugs. The middle circle is all the phase 2 drugs. The outer circle is all the phase 1 drugs. The green slice of the pie at the top is all the biologics, mostly monoclonals, but there's a number of other kinds of biologics. The purple slice of the pie on the right are all the small molecule disease-modifying agents. The blue slice are drugs aimed at neuropsychiatric symptoms, and the orange slice, cognitive enhancers. Those are the 4 main activities in the pipeline. At this time, there were 143 agents at 172 trials. I'll tell you this year, there's 152 agents and 189 trials, but the distribution is about the same. There are a large number of disease-modifying molecules. They account for about 80% of the pipeline, whereas cognitive enhancers and neuropsychiatric symptom drugs are much less well represented. Repurposed drugs were 37% of the pipeline in 2022. They represent 31% of the pipeline in 2023. So much of the drug pipeline is devoted to non-canonical targets, and I consider amyloid and tau the canonical targets. Why am I saying this? It's because there's often a lot of criticism that we spend too much effort on targeting amyloid. As a matter of fact, amyloid represents 14% of the pipeline, 20 agents, so it's not a very big part of the pipeline. Tau represents 9% of the pipeline, 13 agents. So the non-canonical targets account for 77% of all of the disease-modifying molecules in the pipeline. So there's a lot of work outside of amyloid and tau. I'm just showing you this scan because I continue to find it so striking. So this is the first monoclonal approved. This is aducanumab, anti-amyloid monoclonal. Its effect was said to be by the FDA a defining pathophysiological feature of AD. It was marked amyloid lowering. You see the upper two images, you see that red signal that I showed you before, that's amyloid. That's a patient on placebo for 1 year. You see the bottom image, and you see baseline scan has all of that red shadow after 12 months. There's no detectable amyloid in the brain. So the amyloid plaque is removed to below detectable levels. There was about a 30% slowing of cognitive decline. That, of course, was very controversial with aducanumab. It is not controversial with lecanemab. Lecanemab was positive at about this magnitude with all primary and all secondary measures. Amyloid-related imaging abnormalities are the major challenge with the use of these drugs. They require a lot of management. They're mostly asymptomatic, but they can be very serious. And I think we're coming to a place where we understand how to manage it better. So the rights of drug development, very important. You've got to have a great target. You've got to have a great drug. Participant selection is very important. Biomarkers are very important, and a well-conducted, well-powered study are critical to advancing drugs. So I just want to mention the digital technologies and big data. I think, again, this is another biotech opportunity. This has become so important in what we do. So here's just an example of the many types of digital technologies that are currently evolving. They're accessible and have global reach. They have tremendous user convenience and user familiarity. They provide personal health information and are able to provide remote monitoring. They're wearable. They can have continuous data generation. That's why they're paired with big data. AI can assist pattern recognition. They can monitor many things. Just examples would be activity, sleep, blood pressure, pulse, anxiety, et cetera. They can be a trial outcome, though they have not been trial outcomes so far. We'll see. I think we'll see that evolving. And they certainly produce enriched clinical information for the clinician. So developing new digital biomarkers can be a very important area. This is just an example of the kind of data that are going to be generated, whether it be in clinical practice, clinical research, deep dives into the clinical data and research data that are generated to the development of predictive, participatory, preventive, and personalized medicine. These are the places where data are coming from. It's enormous data and requires enormous data skills. So the neurodegenerative disease landscape, the things that I would like to emphasize, of course, the regulatory environment is changing rapidly. We've never seen accelerated approval in neurodegenerative disease before. It's used in cancer all the time. Now we can see that it is applicable to neurodegenerative disease. Advocacy has played a key role in the approval of lecanemab and aducanumab, and will be very important in all of the drug approvals. Of course, contract research organizations are another economic opportunity in the drug development space. Clinical trial sites and clinical trial organizations are very important. We're going to have to deal with medical care systems, and we need to get those trial patients out of the medical care systems. We do a bad job of it now. The biggest challenge for every trial is recruitment. Medicare and insurance reimbursement for new drugs and new biomarkers is critical, and we've got to advocate for that with the advocacy organizations and the professional societies. And then we need guidelines to help excellent use of these new drugs and these new biomarkers. So the drug development is a landscape of stakeholders, academic medical centers, NIH, capital, advocacy, CROs, sites, payers, training, et cetera. And then just to touch on funding before I finish, here's the billions of dollars invested in 2020, 2021, and 2022. And it was very interesting to me that 2/3 of this money was invested in platform technologies, not in individual therapies or individual biomarkers. So they were cell therapies, which we've heard a lot about today, really great talk. Gene therapies, precision medicine, machine learning, new delivery methods. This is what's getting most of the money at this point. So that's where biotech has the biggest opportunities. But of course, therapeutics is very important. and CNS had $2.9 billion of investment during these 3 years. Aging had $0.5 billion, so that was often paired with CNS diseases. Oncology and other then commanded $13.9 billion. So I see biotech opportunities as small molecules. The monoclonals, I think, are going to take off with a success will breed success. Biomarker development, device development, remote monitoring, big data management, and analysis are all going to be critical to all of our futures. So here I would summarize drug development for neurodegenerative disease. It's advancing across all of the neurodegenerations. It's making particular progress right now in Alzheimer's. I expect particular progress in the others. The biomarkers are progressing at a rate that we've never seen, particularly the plasma biomarkers. We're hoping that these lessons will apply to other neurodegenerative diseases. The trials are complex and expensive. There's no question about that. We've got to have a lot of capital in order to get them through a trial. Even proof of concept is likely to cost in excess of $10 million. The 5 rights help guide drug development. Digital biomarkers and big data are an opportunity that I think we can exploit. And the neurodegenerative disease ecosystem has many stakeholders that we have to keep in mind as we work in this landscape. So thank you very much.
Dr. Cummings, I'm sorry I didn't turn the camera to the audience. Also, I'd like to explain to you, actually, what you see on your screen is only 1/6 of the room. Now we are open for the Q&A. If you do have questions, please stand behind these microphones. We only have this camera here, so Dr. Cummings can see you too. No, you cannot do it here. You have to come to here. I'm sorry.
So 23 targets acting on neuroinflammation. Can those targets be classified as those targeting brain cells like glial that initiate inflammation, or those working on soluble factors like cytokines, or systemically or within the brain? Can you speak a little bit more in detail about those targets?
That's a really great question. Thank you for it. The thing that's amazing to me is of that 20-some drugs that are targeting inflammation, almost none of them have the same target. So they are targeting all the things you just mentioned, cytokines and microglia and peripheral cells that we heard about today with sorgamostim. And there's just a myriad of targets within the complexity of the inflammatory system. And different people have chosen different targets within that system. So I'm hoping we're going to be able to learn, for example, what are the most vulnerable targets that we could manipulate best? What are the possible combinations that we could use? Let's say that we see a partial response with 2 anti-inflammatories that are targeting different pathways. Does that suggest we could bring them together? So I think we have to be clever about these analyses. They're probably not going to be straightforward as they come out. Of course, we hope we just have one great win, right? But it's not likely. And so we're going to have to sort of ferret out the information as it comes along. But your question is right on. You know, is there one vulnerable target that people are concentrating on? The answer is no. It is really amazing to me how diverse the targets within inflammation are.
Appreciate it.
Dr. Cummings, we also ran short on time. And thank you so much. Maybe I see you to thank you in person in the biological psychiatry or ACMP meeting. Thank you so much.
I look forward to it. Thank you so much.